Good evening and welcome to today's webinar on elevating outcomes in the era of premium IOLs. I'm excited to have you all here for what will be an educational webinar on how PROcap is the new standard of care for premium IOL patients. This webinar is hosted by Lumibird Medical, a pioneer in delivering advanced ophthalmic technologies to enhance patient outcomes. Our speaker today is Dr. Brett Mueller. He is a board certified fellowship trained ophthalmologist and founder of Mueller Vision LASIK and cataract eye surgery in Fort Worth, Texas. He's renowned for his expertise in refractive and cataract surgery. He is the first LASIK surgeon globally to complete a 2-year fellowship through the World College of Refractive Surgery and Visual Sciences. With over 60 scholarly publications and extensive experience in advanced vision correction procedures, Dr. Mueller is a leading innovator in the field. Today, he will share insights on PROcap for premium refractive outcome capsulotomies, highlighting its impact on enhancing surgical precision and patient outcomes. To make this session interactive, we encourage you to engage with us. So if you have any questions at any point during the presentation, please type them into the Q&A section at the top of your screen, and we'll address as many of your questions as possible at the conclusion of Dr. Mueller's presentation. So without further ado, let's get started. So please join me in welcoming Dr. Mueller.
Thank you so much, Gabe, for the very kind introduction. I look forward to presenting my experience with the Lumibird's YAG device and also talking about PROcap and how I really do feel like it is the new standard of care when it comes to performing YAG capsulotomies, especially in the era of premium IOLs. You know, when I was looking to join my practice, I really wanted to develop this kind of boutique type style practice where I offer patients the best in terms of technology and best in terms of patient experience. And I really feel like that's what this device really is able to afford and able to give my patients. You know, a lot of people's like, what's the big deal? Like, why? What's so important with the YAG? Like, why do we need to pay so much attention to this? Well, in my first year, I will say that, like, you know, I performed hundreds and hundreds of YAG just in my first year alone, and being able to offer it with a device that I can perform very quickly, very efficiently, but do so where I'm not having to worry about pitting the lens and also not producing floaters at all, because, you know, that's one thing to do a perfect surgery and give them amazing 20/20 J1 plus vision, but then you do a YAG on them and now they have to have this stinking floater in the way. This is something that PROcap has essentially eliminated. So without further ado, I'll share my slides and kind of go through this presentation. It'll be, you know, a very quick presentation, but give some of the high points and highlights of this device and how I've kind of implemented it into my practice. Just give it a second here. All right. All right. So, you know, the Tango Reflex Neo really is the latest and greatest when it comes to the next generation of YAG lasers. And it is an amazing device, you know, put out by Lumibird. And really the big key differentiator of this laser, as opposed to other lasers that you'll find on the market, is the PROcap, or the premium refractive outcome capsulotomy. And essentially what you're doing is you are having a 2 millimeter offset behind the posterior capsule, which enables you to be able to make just a few shots aiming in the center of the lens and kind of doing like a cruciate type pattern, or you could do a center shot, and then we'll kind of show pictures of it, where you kind of go circumferentially around, and it really just causes the capsule just to kind of splay open without causing the annoyance of having some sort of floater or something like that afterwards. So question, what is the most common clinical application of a YAG laser? And obviously the answer is posterior capsulotomy. Ophthalmologists were doing these hundreds, if not thousands of these per year in high volume centers. So this is a lot of like what it is that we're doing. And when we're looking at like the cataract journey, really YAG is part of that. You have the cataract, someone comes in for a cataract evaluation. They then have their pre-op, then decide like what lens technology that they're going to be getting. I focus a lot on premium IOL technology, laser cataract surgery, so getting people out of glasses and contacts, then have the surgery. But then there's this second cataract that happens. And we actually consent patients at the time of surgery of letting them know, like, hey, you're going to get this. 50% of the time, people develop this kind of little haze or this kind of membrane that forms on the back part of the lens. So be aware of that, but don't worry, because it's a very routine procedure that we can do to help to fix that. Limitations to a successful YAG outcomes, various challenges with the YAG posterior capsulotomy include lack of uniform training, and then also inconsistent approach to the treatment. And then also I would say lasers too, inconsistency with the lasers. Some lasers just do not operate as well as others. The optics aren't as good. The laser, the way that it reacts and the way that it does the performance of what it needs to be able to do don't work as well. And so that's why you kind of get these kind of inconsistent patterns with different laser platforms that are out there. When a survey was done on YAG posterior capsulotomy, from April to May of 2022, where they looked at 200 consultants randomly selected, and we got 113 responses, kind of looked at, okay, what is the number one pattern that you like to utilize when you're doing a YAG capsulotomy? And about 39% of them said they like doing a circular pattern, and about 54% of them like doing a cruciate type pattern. Personally, before getting the Lumibird YAG device, I was doing a circular type pattern. So a lot of my patients were getting floaters, but I was just terrified of pitting the lens, specifically in the center part of the optic. That right now is not something I have to worry about because I have the PROcap that I utilize. But prior to that, I was doing a circular type pattern. And then, do you use a contact lens for performing this laser treatment? About 52% of patients, or 52% of doctors said that they did use one, and then 38% of people said that they did not. And I personally, I did initially, but I learned how to not utilize a lens when I'm doing my posterior capsulotomy. And definitely with this device, you do not need to utilize a lens. So 51% of people created a 4 millimeter or less diameter posterior capsulotomy. And do you use the laser posterior offset? And about 79% of doctors said that they did, and about 21% said that they did not. Now, the one thing that we all hate is an IOL pitting. Now, a lot of people can argue, well, if it's off in the periphery, does it really matter having an IOL pit? Is it visually significant? Some might say yes. I mean, it depends. Some might say no. But really, in the era of, I do a lot of OD co-management. So my patients are going to their primary eye care doctor, to their optometrist. And if they have a bunch of pits in the periphery, they're probably going to start to question what kind of doctor, what kind of surgeon I am. Like, why can I not do this procedure without getting pits? And so that's like one very important point. But obviously, you are going to notice issues and problems with people's vision if you are pitting the lens, especially in the center part of their vision and the center part of the lens. 25 years of continuous improvements in cataract surgery, 5th and 6th generation phaco emulsification devices, biometry calculations, lots of different IOL designs, premium IOL technology. I say it's amazing to be a premium cataract surgeon in this era, and the technology that we have going forward is just going to be absolutely amazing. It's about time that we have a laser and a YAG platform that has kind of met the demands of what we have to do and accomplish with all of these premium IOL patients coming in. I have patients coming in and they're like, Dr. Mueller, I want to see without glasses. Like, the expectations are immense. So it's nice having a YAG laser, and I can perform a YAG laser capsulotomy that will uphold to the standards that my patients are demanding. And then, of course, exceptional surgical outcomes. So cataract, phaco, IOL, high quality vision. But a part of that is, in that whole journey is the formation of the PCO, doing a YAG, and being able to maintain that high quality vision. I do a lot of light adjustable lenses as well. And one thing with a lot of people, when they start doing light adjustable lenses, they'll notice that, the The visual quality is amazing. The silicone optics incredible. The fact that we can make fine tunes and adjustments to their vision after the surgery is just amazing technology that we're able to offer patients in 2025. Feels like we're in the, Star Trek future generation type stuff when we start, thinking about it. But the one drawback, or I wouldn't say drawback, but the one thing that people notice when they're performing a YAG on these silicone lenses is that they do pit very, very easily, especially when using a standard YAG laser when performing this. Well, when we have the Lumibird YAG laser, especially when utilizing the PROcap, we are able to perform a good YAG capsulotomy, being able to do it to where we're not creating floaters, so we don't have to do a circumferential pattern at all by utilizing the PROcap and being able to get a really good outcome for our patients. Now, what led to this discovery of the PROcap? Or like, hey, like, why are we going to extend this out 2 millimeters past the posterior capsule? Like, how is that going to be a benefit? Or like, what is different about that versus what we normally do when maybe we do like a 300 micron or 500 micron offset? Or maybe, some people don't even use an offset, just using the photo disruption that we get from the YAG laser to be able to cause that photo disruption that we want to be able to break apart the posterior capsule. And it was really this doctor out of Germany, Dr. Karl, that made the discovery that, when you do this 2 millimeter offset, that you're able to really get this kind of really nice pattern and this photo disruption utilizing the jet propulsion of this device to be able to really break apart the electrons and really to cause that photo disruption of the posterior capsule. So basically, what he discovered is that when you go 2 millimeters posterior, staying in the center part of the lens and create a shot, you have this really nice opening that you are able to create. That creates about a 3 millimeter opening. In my experience, it does that with just one shot. And then what you then do is you then go circumferentially around that area, creating a few more shots too. So you can see it kind of creates this kind of hexagonal shaped pattern, and being able to apply the laser in a few more locations along the periphery will enable you to be able to widen that posterior capsule up to about 4 or 5 millimeters. And the clinical rationale and the mechanism of action is that with the PROcap, you create a brief low energy YAG laser pulse that's delivered behind the posterior capsule. Ionization of the intraocular matter occurs with plasma formation, causing rapid growth and decay of a cavitation bubble and accompanying shock wave moving towards the posterior capsule. And then with sufficient posterior offset and collapsing cavitation bubble produces a powerful hydraulic jet effect, cleanly dissecting the tissue with minimal debris. So it's this jet effect that I was kind of alluding to a little bit earlier that is actually creating this disruption of the posterior capsule. And that's what's enabled us to be able to show minimal debris, no posterior floaters, and then also minimizes the risk or almost eliminates the risk of there being any sort of pits of the lens. So this is what they kind of found, and the conclusion was, we consider strict treatment guidelines are necessary to consistently deliver perfect results from a YAG capsulotomy procedure. In our opinion, investigating time using a contact lens and fixating a patient's head will minimize complications. Moving the laser focus 2 millimeters behind the IOL into the vitreous will mitigate IOL damage. Laser equipment with an integrated posterior offset of 2 millimeters would be recommended. And so this was kind of like led to that discovery of the PROcap. So PROcap, what it does is it creates a clean, well-constructed capsulotomies with no IOL damage and few posterior post-operative iatrogenic floaters. So in really setting the standard for us being able to perform a very good high-quality capsulotomy. And the other thing too is, like with this device, is not only the YAG laser, but also the SLT laser that's built into this. It is absolutely incredible. And the one thing too is that you can move the light wherever you want, and that laser is going to keep firing. oftentimes, like there's a certain, with a lot of other SLT lasers, there's a certain spot where if you're, within about 30 or 40 degrees of like where you're sitting and you're trying to get the lighting and trying to look at the angle where the laser just won't fire, like it can't fire through it. Whereas this device has the ability to be able to shoot and being able to perform the SLT in the angle, no matter where you're putting the laser, where you're putting the light to be able to visualize the angle, which is very beneficial, very nice. So the PROcap, of course, indications, and when doing any sort of laser capsulotomy is indicated for the treatment of the posterior capsule opacification when patients have symptoms of glare, halos, or decreased vision. Doing a posterior offset of about 2 millimeters and starting at around 2 millijoules. I usually bump it up maybe to around like 3, maybe 3.5 millijoules. When I'm using an LAL lens, I usually start at around 2 because I just know it's more sensitive to the to pitting. So I just want to make sure that I have that perfect amount of energy to be able to do the treatment that I need to be able to do. But usually, if it's not an LAL lens, usually starting around 3 millijoules, but with the LAL lens, I start around 2. Treatment preparations, just like anything, you adjust the slit lamp, binoculars one at a time to ensure that you are in the correct location. Patient is comfortable, which is this laser really, it's got little footrests for them to be able to put their feet on there, and being able to get them into any sort of orientation and position that you can. It's very accommodating, very comfortable for the patient. And, of course, making sure that they're dilated, add some anesthetic, and then you're off to the races. So the treatment, just like you would do normally with a normal capsulotomy, I don't use a contact lens, but you could if you'd want, if it increases your comfort level. Occasionally, I will use a contact lens if I'm doing an LAL, but most of the time I don't need to. And then you just set the magnification for about 10 to 16x. And then, you can see the pattern of how they recommend that you do this, and it works very well. So you have this center shot that you do at the very beginning, and then it creates this kind of hexagonal shape pattern. And then at each of the little corners that you see, you can then further apply more energy at those locations, more shots, and then that'll further cause the posterior capsule to just draw back and not create any sort of floaters at all. The mechanism of action is a small amount of laser energy is delivered behind the posterior capsule for a brief period, about 4 nanoseconds. A massive power spike is created and a localized target area about 8 microns. And the power is the energy divided by time. So back in our college days, so we get about, for 2 millijoules, it's about 0.002 joules per a very small amount seconds, and that gives us about 500,000 watts. And this is enough to strip the electrons from their atoms, causing ionization to occur. The spark you see when firing a YAG laser is the flow of electricity between the ionizing atoms, and it is equivalent to a lightning strike in nature, which is pretty cool. This results in the immediate vaporization of matter, causing the formation of these cavitation bubbles. Now, historically, it's these cavitation bubbles that would cause the disruption of the posterior capsule. But that's it's different than what we are doing with the PROcap. So, here in a normal situation where we're doing the photo disruption, the laser is not the principal mechanism of tissue disruption. It's the massive power spike with this 8 micron target area, and then the growth and decay of rapidly forming the cavitation bubbles. And this cavitation bubble generates a mechanical wave which propagates towards the posterior capsule with enough force to break tissue. Light energy is transformed into mechanical energy, which breaks the tissue. This is the principal mechanism employed when using normally when you're using a different laser other than what you would be using with the Lumibird YAG laser. But if you're like within 500 microns, that's those cavitation bubbles that's causing that photo disruption. But here, what you are seeing is that with this 2 millimeter offset, is that the YAG bubbles behaves quite differently, completing its natural life cycle and growth and decay. And if we consider that the IOL is like a solid boundary in front of the cavitation bubble, it has been observed that the solid boundary significantly influences the cavitation bubble dynamics, causing it to collapse asymmetrically. And this is what we call the jet effect. So this jet effect is what is causing that disruption of the posterior capsule, minimizing the risk of pits, minimizing the risk of floaters. And that's why we are getting a different, this is why we are getting a different, guys, stop. This is why we're getting a different effect when we're doing this procedure. Due to the safety margin introduced by PROcap and up to 2 millimeters posterior offset, it is without question safe to fire the initial opening pulse into the center of the visual field and build capsulotomy architecture from the inside out. So we now have introduced excellent IOL safety with an approach to capsulotomy creation that does not result in iatrogenic floaters. And that's it. So, you know, this laser has really been a game changer for me and for my practice. It's awesome to be able to offer a procedure that we do all the time that most people are like, yep, you're going to get floaters. You're going to have this problem. You're going to have this issue, and really haven't really seen patients that complain about that anymore. And then also minimizing the risks of pitting as well. So with that, I will stop sharing.
Perfect. Thank you so much for that presentation. So I really appreciate it. We do have a few questions that have come in. So I'll just start reading them off one by one if you don't mind responding. So the first one is, I do a lot of LALs and struggle with pitting the silicone lenses. How often do you see pitting in your LAL patients when you do PROcap?
Yeah, before PROcap, I would see pitting all the time. I mean, and that's why I would do a circular type pattern with when I was doing the LAL, because there was no way I was going to risk pitting the center of that lens. I mean, it didn't really affect the vision, but it definitely took away style points when I was doing my YAG capsulotomy. And so, and you know, the concern is like, what would other doctors, referring doctors, see when they would notice the different pits that were along the LAL lens? But since PROcap, I have not had a problem or an issue with pitting whatsoever. It's pretty much essentially resolved that issue, which is pretty nice. And I do YAG a good portion of my LAL patients. I would say probably about 30 to 40% of my premium IOL patients probably get a YAG, but my LAL patients, it's probably around an 80 or 90%.
Okay, very good. So the next question is, can you do PROcap with other YAG lasers?
You can't do it like where it's nice and easy, where you just flip the switch and enable it to be able to perfectly be 2 millimeters offset. I guess you could guesstimate and go posterior to it to where you think you're like 2 millimeters back, and then kind of artificially create that thing. But there's not a means to be able to go past about 500 microns with most lasers. Most lasers tap out at 500 microns.
All right. The next question is, have you had or do you worry of any adverse events doing PROcap?
I haven't really seen or worry about anything other than what you would normal risk factors that you would get doing a normal capsulotomy utilizing PROcap. So it's been actually it minimizes risks and minimizes complications associated with what we normally see when we're performing a YAG capsulotomy on patients.
Right. The next question is, I just bought the Tango Reflex laser. What is your advice to someone starting out doing PROcap?
I would say start out initially at 1,000 until you get comfortable, and then you can then start going to 2,000. And I say 1,000 microns, or like 1 millimeter, and then go to 2 millimeters. So that's basically what I initially started out at, and then start doing just with the cruciate type pattern. So you know, if you're nervous about doing that initial shot right in the center of the lens, then you can you know, do a nice cruciate pattern, get comfortable with that, do 1,000 microns first, then go to 2,000 microns, and kind of work your way up, starting at around 2 millijoules. You could start at around 3 millijoules, and then kind of titrating your power up as needed.
Okay, thank you. And we've got two more questions. The next one is, do you ever find you need to go to 1 millimeter because you can't get the effect at 2 millimeters, even at high energy?
Yes, I do. So if you are, if you have like a very dense PCO, you might have to titrate it to about 1 millimeter. And usually I can get it at 1 millimeter. There has been a couple times where I haven't been able to get it at 1 millimeter. And so that's what I'm putting the lens on. And that's where I'm going, okay, let's go to 300 or 400 micron offset. And then trying to get it that way using, the cavitation bubbles to be able to get it. If you have like a very, very dense PCO, you are, it's possible that you might not get the effect by using the PROcap.
All right. And then the last question we have is, when I have a 2 millimeter offset, is there a risk of impacting the retina?
So there hasn't been any evidence to show that. There haven't been studies to kind of look at that and show that, is there something to where the reverberations that you're getting in the midvitreous, is that going to cause issues at the aura? Is that going to cause issues with the retina? And then there hasn't really been any sort of evidence to suggest that you are subjecting the patients to increased risk of a retinal tear or potentially a retinal detachment utilizing PROcap.
Got it. There's actually one more that just came in. That's, what is the max energy you feel comfortable at 2 millimeters before you need to go to 1 millimeter?
5. I'll go up to 5 millijoules.
Okay. All right. Well, thank you so much. I appreciate you answering those questions. Thank you for your presentation. Your expertise and passion for advancing cataract outcomes has truly highlighted the transformative potential of this technology. I want to thank all the attendees for joining us today and for engaging with your questions throughout the session. And as we wrap up, please keep an eye out for the future further communication from Lumibird Medical in the coming days. We'll be sharing additional resources and updates to continue this important dialogue. If you have any follow-up questions or wish to connect directly, please feel free to reach out by emailing me at glewis, that's GLEWIS, at lumibirdmedical.com. And on behalf of Lumibird Medical, thank you again for your time and participation, and have a wonderful night.
Thanks, everybody.